right. Thank you for that wonderful introduction. Do you all see my screen there? Should say shoulder and hip embolization.
Yes, sir.
All right. So again, thank you for that wonderful introduction, and thank you so much for having me here. It's a real honor. So today we're going to take a very brief dive into shoulder and hip embolization. My name is Ahmed Frog. I'm the CMO of the Advanced Vascular Institute. So our practice is outpatient predominant. We do a lot of procedures at the hospital too, but we focus on the outpatient, and we're predominantly MSK intervention. We do PAU, UFI, HA, PD, and veins, and interventional oncology at the hospital, and we always take a multidisciplinary approach to each consult. So I'm 100% referral based, and everything that comes through my door, for the most part, has already been discussed with another physician. And as I said, referrals drive our practice. So mainly sports medicine, primary, and ortho. So brief introduction to shoulders. This is chronic shoulder pain that usually persists despite conservative therapy. And transarterial embolization is a minimally invasive option for refractory cases. And essentially, we're targeting the neovascularity and the blush, so to speak, that's causing that pain. And the common causes are going to be predominantly adhesive capsulitis and to a lesser extent, osteoarthritis. For hips, we're looking at hip pain that persists despite conservative management. We're going to get an MRI typically, and we're looking for trochanteric bursitis and to a lesser extent, osteoarthritis. So the pathophysiology, we're looking at chronic synovitis and bursitis that's causing fibroblastic proliferation and thickening, and that angiogenesis and abnormal vessels are perpetuating that inflammation and pain. You're going to get increased factors in cytokine upregulation, and then that hypervascularity is visualized on angiogram. You usually can see a joint on fire, and that's what we target for embolization. So the embolization technique, we get into our target vessels and we go as distal as we can. We identify the hypervascular blush and we treat them one by one. Just a normal low pressure pulsed injection. And then we check after. A lot of times the endpoint is when that blush is gone. I often go small and check it again. If there's still blush, I add a little bit more. And if you have any vasospasms, treat that with nitro. So the embolic agents that are typically used are where a lot of people are predominantly doing the resorbables. So we're going for the Pramaxin, Imipenem, and the newer embolics like the Sakura beads, Nexsphere EP, and Kipsa. And for the expert users, to a lesser extent, you can use Embo spears. You just have to be very careful with your injection. And post-procedure, depending how you go, majority of it is either pedal or radial for us. So we use a compression device after we observe for any bleeding. Anyone who I think is going to be difficult for a TR band or a pedal band, I'll just hold 10 to 15 minutes. And then we tell them to take it easy for a few days. And I always do a 1 day follow-up just to check the arterial puncture site. And then from there, we follow up our 1, 3, 6 months. So these are my weapons of choice. I have a kit that I use that has everything I need on. I'm really particular in my medallions. I think they're wonderful for MSK embolizations. You have great control. I always use a Slim 4.5 from Merit and usually a splash or glide wire to get into the axillary arteries or the branches off the profunda. And then almost always I'm using a 4 French glide cath or a burn type base catheter. I've become really partial to the Tellus and Volute for their size and the swan neck from the pedal approach. Um, and then the Asahi Meister wire there, I use that in just about every case. That's my MVP wire. It's wonderful, makes my life very easy. So this is a little bit on shoulder anatomy. And essentially you're looking for all the shoulder, the arteries that drape around. So the anterior posterior circs, the circumflex, the thoracoacromial are kind of our main targets there. So what we're looking for, as we mentioned earlier, is adhesive capsulitis that's refractory to conservative measures. I get an ACEs. I'm looking for people that have had failed conservative therapy for a certain number of time, and then I usually get imaging before MRI if I can, but at least an X-ray. And then we do a very detailed. Anyone who comes in my building, we do a vascular workup. I get radials, I get pedals. If I think they need ultrasound, we'll get it, and then we always get an Allen's test. Just make sure we know what we're getting ourselves into. If there's any question, just get I have an ultrasonographer in house, so very important to get an ultrasound and know what you're getting yourself into. Exclusion, anyone who's had recent fractures, instability, significant tears, and obviously if you have really bad PAD, pregnancy infection, allergies, and coagulopathy, you can use your judgment in those cases. So we go radial axis. It's preferred. It's quick, easy. It's comfortable. Other than the 3 seconds of discomfort for lidocaine, we use a small sheath, and then we give the verapamil nitro and heparin cocktail. And then I use the microcatheter for subselection. And then if I need to, some of those vessels are if they're overlying, I'll take in multiple obliquities. So the recent data has been really good. If you look at the studies from Venti and Guest and OEIS, well, and Dr. Akuno's work, you'll see that 79% of pain is reduced within the first few months. And that's usually a long-lasting pain if you did the appropriate patient selection. Very low complication rate, transient numbness and post-embolization pain usually goes away, and it's very rare. And then our evidence is limited at the time, but there's ongoing trials that are needed, and we have a large data pool, and I think that the evidence is going to continue to show wonderful results. So some challenges we see with shoulders, you can have a high takeoff, you can have loops. The tortuosity is very variable, and you usually have an idea right when you start. If you start seeing squiggles and wiggles instead of straight lines, you know you're in for a hard case, and these vessels are very easy to spasm. So if anyone wants to get in these type of procedures, please take precautions and take your time. This is an example of a really difficult case. We came in from a radial approach there and essentially had a 180-degree turn on the way back. This is a very small vessel. If you're going to use a rim or a mini rim, I caution you to be very careful. I like shapeable wires and I like shapeable catheters. So using a Tellus Evoluti with a Meister on here was wonderful. We were able to get around the bend and get to the arteries that we needed. And I do a lot of these, so you see a lot of just weird variant anatomy. This is just another case that it may look easy, but this was a bear of a case. And we're in a field where a lot of the cases we do, you get that instant gratification. This was a gentleman, one of my first cases, that firefighter, 5 years unable to raise his hand past what you see on that picture there on the left and that picture there on the right. Immediately post procedure is able to do that. So you can see a lot of the MSK embolization, they have immediate results, and these are life-changing procedures. So just a brief talk on hip artery anatomy. The main vessels you're going to be going for are kind of the lateral and medial circs, and then some of these superficial vessels that kind of drape around. And sometimes you'll have to go in through the internal division and kind of map out. These can be a little tricky, and you're really looking for the vessels that kind of drape around the hip there. So we're looking for anyone that has functional limitations, had hip pain for a while, anyone who's failed conservative therapy. And the things I'm looking for on MRI are that trochanteric bursitis and the osteo. These are typically not surgical candidates or people that just don't want surgery. This is a great alternative for people who want to hold off on hip replacement, and we've helped a lot of people with significant pain. Exclusion criteria, like kind of we mentioned above, anyone that has fractures, instability. Very important that you rule out AVN. I think the hip, more than any other joint, has a predisposition to this. I always get an X-ray. If there's any question about it, get an MRI, and I would say almost 95% of my patients are getting MRIs on this, and obviously anyone with active infection or pregnancy, and use your judgment for PAD and coagulopathy. So there's many ways to do this. You can go ipsilateral up. That can be a little difficult given the proximity of the profunda and the circumflex branches. But if you bear bracket like our esteemed speaker right after this, it's a wonderful approach, and it can be great. Contralateral is, what they've taught us historically, up and over, go down, longer catheters, a little bit more time, and you lose a lot of torqueability. And then my preferred is the DP or PT approach. Straight shot up, patients love it. Now you do got to get creative with those angles, and this is where those shapeable micro wires and micro catheters come into place. This is just an example of some pedal approach. Some of the hips that we've done, pedal approach coming in, we lock in and then lock in those lateral and medial vessels here. These can be tricky cases. So if you're not using shapeable wires, you need to start using them. I show this slide. I know this is not a knee slide, but I show this, you can run into surprises whenever. This is a patient that initially came in for a GAE, but after doing a thorough exam, didn't have pulses. And worked it up a little bit more, and when we came down angiogram, you see that he just has nothing below his popliteal. So as you see here, the genicular artery is actually what's feeding the majority of his flow distally. So make sure every patient that comes in that door, you're doing a thorough assessment and you're doing what they need. So this gentleman ended up needing an atherectomy. His knee pain actually disappeared and he was fine after that. And you would not want to do an embolization on a patient like this because you can end up taking his flow distally. So just some recommendations for all of you all out there. You are the final boss. Make sure that every patient you see, whether it's a referral or you're seeing for the first time, that you're making the decisions you want to make. Your results are going to speak for yourself. I always make sure that, I talk to my sports medicine, primary care, ortho brethren. We're making a multidisciplinary decision at the end and become a friend and colleague to everyone else. You're not competition. I don't care what's going on there. There is so much disease out there that if you market yourself appropriately and make yourself useful to everybody, you're going to do good no matter what. So work both with the patients and the referrals for any denials. Be thorough, market to your strength, use the right devices like we talked about. I have a wireless ultrasound in office that makes my life so easy. You take that around, you can essentially in the room know exactly what you're getting yourself into. Treat your staff well. They can make or break you. Make sure you have your algorithms printed. You don't want to get in a situation where you're, dealing with somebody who's brand new and they have no idea what's going on. So have your cheat sheets all around and then set expectations. Um, in the beginning, all this stuff is going to be hard, but it gets much easier as you go. Here's some references, and thank you so much for having me.
Thank you so much. So I'm going to ask you a question while we have some questions kind of come through in the chat. What does follow-up look like for you as this is a clinical specialty and as we transition to a clinical specialty? What does follow-up look like and what are your timelines?
So everyone that comes in, I always do a site check the next day, just make sure the arterial puncture site is okay. And then I do a 1 month, a 3 month, a 6 month, and a 12-month follow-up. Everyone has my card. The number on there is 24 hours. If someone needs to be seen earlier, I would just see them. If there's any questions, make sure they have access to be able to, if they need to show you a site or they have a question about something, they can email you so you can see it quickly. But anyone who needs to be seen, I get them in quick. So, but the follow-up's typically 1 day, 1 month, 3 months, 6 month, and 1 year, and then we follow up yearly after that or as needed.
And to kind of follow up on that, how do you manage these patients post-operatively?
So post-operative management in the interim, we usually, we'll watch them, make sure that there's no hematoma. And then post-procedure, we're often getting updated imaging. I think that updated imaging kind of justifies what you've done. When you get that MRI after and it shows that synovitis or that bursitis is kind of calmed down, that right there kind of shows you where you, and then the patient, the WOMAC score, their pain score, that tells you a pretty good indication of where you're at.
Okay. And then if you have other questions, you can put them in the chat as well. But since you mentioned it with the embolics and how the experts will use embospheres, how do you minimize the risk of non-target embolization?
You do a lot of these, and you carefully sub-select. I do not recommend you use any permanent particles in these joints unless you've done a lot of these and you kind of have an idea of how the embolics work. I would say stick to resorbable embolic and carefully sub-select. And even with that, you still have to be careful. There's no easy way in or out. But I put that up there because I've used all three and I've had great results with all of them. Resorbable embolics almost 99% of the time, but there are rare situations where you need to use that. But in the beginning, I would highly suggest you stick to resorbable embolic until you know what you're doing.
Okay. And then you did mention some research done by Dr. Akuno. Have you seen any recent studies, trials, or advancements that may make you change how you do your practice in the near future?
Yeah, so pretty much if you go to any of these conferences and you see the results by Dr. Akuno and Dr. Little and Dr. Osman coming up, it makes you want to change your practice because it makes you want to do more of these. You see how amazing this is, and people are suffering worldwide, and you see just the number, the disease prevalence. There's more and more studies coming out there, and I think this is just the beginning. I think this is going to take over, and you're going to see more and more of these.
Okay. And we have Dr. Ahmed up next, and we just have one thing. He's coming from a case. So you have one last piece of information, a clinical pearl to share with us?
Absolutely. We're in a field that you really get to dictate what you want it to be. If you want to be 100% and you want to go all in and you want to have a clinical practice, you get to dictate that. What that means is you need to see your own patients. You need to get in clinic. You need to be following up with other providers. You need to do everything you can to manage these patients. Be that warrior that Dr. V talks about. And whichever model you want to go into, as long as you see your patients, you own them, and you're the one treating them, you're going to be able to run whatever practice you want. And people are going to, once they see results, they're going to start sending it to you. So I highly suggest you all get out there, know that there's different models. You can be in an outpatient setting almost full time and do really high end IR, um, and just do really good work. And, I'm really excited because my good friend and colleague next is going to tell you all about, the fun stuff he does. And I think if you mimic kind of what he does in his lab, you guys are going to be very successful.
All right. Well, thank you so much for your time. And we're going to move over to Dr. Ahmed. He's going to talk to us about GAE. He's widely considered as an expert in GAE. He's one of the first physicians in the U.S. to do this, and we're very grateful to get an opportunity to learn from him. So if you will share your screen with us, and we'll get started.
Awesome. Thank you guys so much. Ahmed, good to see you, my friend. And I apologize. I was actually doing a GAE, so thankfully we just finished. So let me share my screen. Let's do this. Everybody can see this, hopefully.
Yes, sir.
Okay, cool. All right. Hi, guys. Thanks so much for logging on and spending your Saturday here, Hunter and team. Thanks for putting this together. It's exciting to actually be able to join. I've missed the last couple of years. I apologize because I've been traveling a lot, but I'm going to jump right into it. We're going to talk about GAE, which is obviously a very exciting new procedure in IR, but not so new anymore as much. So when we talk about knee OA specifically, it's a pretty debilitating condition. It's characterized by pain, stiffness, loss of function, and it's a public health problem. 15 million patients in the U.S. alone are impacted, and it's the most common cause of chronic pain and physical activity limitation in adults. A lot of times I like to basically say it's one of the first things that happens to normal, healthy patients or people in general. But what comes with this pain and physical activity limitation isn't just like a QOL thing. It's actually associated with an increased incidence of coronary artery disease, and it's also linked to mental health consequences like depression and suicidal ideation. And a lot of these are, again, related to loss of independence, loss of sort of function. And so you can imagine if you're you start to get debilitated, you can't move around as much, then your risk of coronary artery disease goes up, and you start getting depressed because you're kind of losing your kind of your free will kind of thing. So when we think about the pathophysiology of OA, this has historically always been considered to be kind of a degenerative disease. We always just say it's a wear and tear disease, but the reality is if you look at rheumatology literature over the last 10 years, it's very clear that this is a very complex disease with multiple clinical phenotypes. And among those phenotypes, it's very well established that a primary phenotype of knee OA is actually neoangiogenesis and synovial inflammation. And that brings us to this very complex slide of sort of this inflammatory cascade that occurs with OA. Again, there's not, this is a very busy slide, but what really is important is that you have some sort of abnormal mechanical load that what that does is that basically starts this process. And it's basically a positive or forward feedback loop of cartilage debris and catabolic mediators that enter the joint space. And then this begins that feedback loop where essentially inflammation occurs, new blood vessels grow into the joint, and they start bringing nerves with them. And this is an area that typically doesn't have nerves. So now you're making an aneural space sensitized, and that leads to essentially pain and disability associated with that pain. And that brings us to what the treatment gap is with OA. So most therapies that exist for knee OA are largely ineffective. So we have physical therapy, NSAIDs, Tylenol, and steroid injections, and none of these things actually work directly on synovial inflammation. And that could be one of the reasons why they're not very effective. But when these medical therapies fail, really your next option is knee replacement or surgery. And where the treatment gap exists is that over 50% of these patients in whom these medical therapies fail are actually not candidates for surgery. They either don't want surgery, or their disease isn't advanced enough for surgery, or they have comorbidities like diabetes, obesity that prevent them from getting surgery. So it's pretty, it's a huge gap because there's so many patients with knee OA, and it's actually estimated that as of last year, that's about 5 million patients. So that really dwarfs almost everything else we do in IR in terms of, patients that may benefit from our therapies. And that's why GAE, I think, has gotten super popular. because it's a minimally invasive method to actually selectively catheterize and target these abnormal, neovessels of the knee. With the idea being that if you embolize these pathologic vessels, you essentially can stop or slow down this synovial inflammation and neoangiogenesis process. You're essentially interrupting that, inflammatory cascade, and thus sort of stopping the, inflammation and the pain that sort of comes with it. And this is sort of what this looks like. Here's an initial angiogram. This is actually the inferior lateral genicular artery. So this goes to the lateral compartment of the knee. And you see this kind of blush staining, kind of looks like a Monet, painting there. And that's what we're looking for. Those are what we consider the abnormal neovessels. And this is what it's supposed to look like post-embolization. So you can see here, we've gotten rid of a lot of that blush, but we've preserved the normal artery. So the goal is to not, knock out the whole artery, but it's actually just to get rid of those neovessels. So, it's very important, obviously, to understand what the anatomy of the knee is. And so we really have kind of 6 workhorse arteries. And, there's more and more arteries that we're looking at, but these are kind of the main ones. So just looking at the ones that are highlighted in red text. So we have, coming down the femoral artery, we basically have the descending genicular artery. This is one of the most important arteries that we do in GAE. And specifically, it's the articular branch of the descending genicular. So it's kind of that inside track or more medial artery. Then we also have the saphenous branch of the descending. This is the artery we want to avoid. This goes mainly to skin and nerves. And then coming down, into the popliteal, we have kind of the 4 workhorse arteries of the knee, which are denoted by the quadrant of the knee that they supply. So you have your superior lateral, your superior medial. You also have this median genicular. We try to avoid this. This typically goes to the cruciate ligaments. Then you have your inferior lateral and your inferior medial. So, superior or inferior, and then medial or lateral. And then the last artery we have is this anterior tibial recurrent artery, which comes off the anterior tibial artery. This also goes to the lateral compartment of the knee. And these are the main arteries that we sort of look for. And so what does that look like in an angiogram? This looks, slightly a little bit harder than that cartoon I just showed you. But once you do enough of these get very obvious. So you can see here's your articular branch. Here's your superior lateral. Here's your superior medial. So the superior lateral and medial kind of form this seagull appearance or, bat wing appearance. Then you have the inferior lateral, which has more of a horizontal C shape. And then you have your inferior medial, which has more of a 45-degree hockey stick or J shape to it. And then your anterior tibial recurrent artery. When we see these patients, not only do we just, ask them how they're doing, we want to try to objectively grade their pain. And the most objective thing that we have is what's known as a patient-reported outcome metric, which is actually the WOMAC, which is most commonly used in the U.S. It's a self-reported questionnaire out of 96 points, but we're really focused on this first category, this pain category, which is scored out of 20. And so you'll see most studies report either a WOMAC, or in Europe, there's something called the KOOS that they tend to use more often. So in addition to doing the WOMAC, we obviously also do a history and physical, and then we also do a weight-bearing knee radiographs, and that's to grade the severity of OA. So who are patients that are eligible for GAE? Mainly, we're looking for patients who have knee OA, as I mentioned, that have failed conservative therapies. And conservative therapies there's a ton of different things that patients can try. Or have tried. More often than not, when you've seen these patients, they have failed many of these things. And this range of refractory period is typically 3 to 6 months. But again, when you see these patients, it's usually in the magnitude of years that they have been trying these things. As I mentioned, knee radiographs are how we currently use to grade the severity of knee OA. This has many limitations, but it's probably the easiest and simplest way to sort of do this. As you can see here, we use this grading classification called the Kellgren-Lawrence grading classification, with 4 being the worst. Essentially, it's bone on bone, where the bones actually touch each other. And grade 1 is essentially a normal knee joint. There's actually grade 0, which is truly normal, but 1 is essentially a normal knee. And then you have 2 and 3, which is somewhere in between, essentially graded by the amount of joint space narrowing. This is important because not only do we want to document that patients have OA, there's also some literature that suggests that the grade 4s do worse than the grade 2 and 3, which has anecdotally been my experience that they tend to do slightly worse. So as far as how we do the procedure, we perform angiography of the affected limb from that superficial femoral artery. So if you have right knee OA, we're going to puncture your right superficial femoral artery or your femoral artery. And then we're going to go ahead and catheterize the abnormal genicular arteries with a microcatheter. We're going to confirm that blush, and then we're going to embolize that genicular artery. And there's a wide range of embolics that you can use. In America, we've typically started with permanent microspheres, whereas in Asia they started with what's known as imipenem psilocin, which is a antibiotic crystal that has embolic properties. But the reality is that everybody's kind of moving towards these temporary or resorbable particles as we move forward. And again, the idea is to prune these vessels, is to get rid of those neovessels, not really knock out the normal artery. So here's an example. Here's a patient with medial compartment knee pain. So we're going to target the arteries of the medial compartment first. So here's the articular branch of the descending genicular. We're going to catheterize that. And once you catheterize it, oftentimes you see the blush more effectively. So you can see down here, there's some neoangiogenesis. We're going to proceed to embolize this vessel with some small amount of embolic. This is one of my first cases I ever did. And you can see here, after just a very, very tiny amount of embolic, it's usually like 0.3 or 0.4 cc's of embolic. You can see that those neovessels have been reduced. And then we're going to go ahead and catheterize the inferior medial. So we're going to look for every single artery that we can get into that goes to that area. And now we're evolving into every artery of the knee. And you can see here, this is the inferior medial genicular artery, and there's a tremendous amount of blush here. So we're going to go ahead and embolize this as well. Again, a very, very, very small amount of embolic. And so after, again, 0.4, 0.5 cc's of embolic, you can see here that blush or staining has been reduced or eliminated. Here's another example. This patient had lateral compartment pain, and this is the initial angiogram from the superficial femoral artery. And you can see here we've also placed a BB marker at the site of pain for the patient. So we're going to start here. Let's go into the inferior lateral genicular artery because now we're focused on the lateral compartment. We catheterize that branch. And this is a good example of why we need to catheterize the branch to really see that blush. You could see that on that initial angiogram, we didn't really see a great blush, but once we get into it, we really can appreciate more staining there. Again, this is pretty close to that BB marker. We're going to go ahead and embolize this. This gets to be very repetitive the more you do this. And again, very small amount of embolic, like 0.4, 0.5 cc's. You can see here we've essentially eliminated that blush, and we still have flow within that parent genicular artery. Are we done? Nope. We're going to go ahead and go into the superior lateral genicular artery as well. So we're going to go ahead and catheterize that branch. And again, you can see here, once you've catheterized it, just like the prior, you appreciate that blush much more once you've catheterized that vessel. And you can see this is pretty close to that BB marker as well. So we're going to go ahead and embolize this branch. And you can see here, post-embolization, tiny amount of embolic. We see that blush has been resolved, and we have preserved flow in the parent artery. Here's a dynamic example. This is what this looks like in real time. So you can see on the left, this is pre-embolization. You can see that inferior lateral genicular artery. We see a fair amount of blush there as we continue to inject. And if you turn your attention to the right in the post-embolization, you can see that when we inject, we still want flow through that artery. We don't want it to be static, but we want that blush to be gone. So you can see that blush has been eliminated. Post-procedure, these patients go home the same day. This is now for us. Most of us who do this pretty high volume takes us way less than an hour, typically 30 to 45 minutes. We often do it with just local anesthesia only. And these patients do get followed closely because we are still, as Dr. Frog mentioned, in the early phase of sort of our experience with GAE in terms of literature follow-up. So we really want to follow these patients closely out to 2 years. It's important to mention that it's normal and expected to see kind of some mild skin changes. There's tiny little branches that go to the skin or cutaneous vessels that arise from the geniculars. So this is sort of normal to see that, but this is transient and resolves by 1 month. And it's also normal to see some increased pain for a few days after intervention, especially if you're using permanent microspheres. There is a tremendous amount of data now on GAE. There's over 1,000 patients that have been reported throughout the world. And you can see here are some of the initial studies from sort of the pioneers of this procedure throughout the world. And you can see here Dr. Kuno is kind of the original person. And what's important to note is that if you look at this, no matter what country, what patient population is being treated, the success rates are actually very high and consistently in this 80 to 95% range. That's important because it really sort of speaks to the validity and reproducibility of this data throughout, the world. As I mentioned, Dr. Kuno is the sort of pioneer or godfather of this procedure. He has the largest experience to date in publication with the largest follow-ups out to 4 years. So he's actually been shown that patients out to 4 years can have durable pain relief, and also has MRI data showing reduction in synovitis at 2 years. So very important longitudinal data to sort of speak to the durability as well as the safety. There's no effusion or osteonecrosis that's been reported in his experience. Now, with that said, why are we just doing this or offering this sort of routinely? Well, the reality is that we're still in a sort of early phase in terms of the data. And it's been shown that all pain interventions related to arthritis have a high degree of placebo effect. It actually can be up to 50%. And so because of that, there is a potential risk that what we're doing has a large degree of placebo associated with it. So in order to validate this, we really need to do sham controlled studies as well as studies that compare GAE to other sort of what we consider standard of quote unquote standard of care therapies. Fortunately, there's a ton of these that are underway. And I think in the next couple of years, that's really going to shape the future of GAE in terms of guideline incorporation and making sure, insurers pay for this procedure. And then I think Dr. Farag probably touched on a lot of this. I often say that, GAE is Pandora's box, because once we validate that, really this concept of embolizing for inflammation or chronic repetitive use injuries will sort of be open, and we can kind of embolize everything else. And whether that's frozen shoulder, plantar fasciitis, greater trochanteric bursitis, facet disease, all these things have been reported so far, but they're much more in their infancy in terms of literature. So I'll stop there and conclude that, NEOA, a major health problem. Up to 5 million patients in the U.S. suffer from inadequate treatment. They're literally out there with no option available to them. They're just suffering in pain. And it's important to mention that with NEOA, synovial inflammation is thought to be a major driver of the process of arthritis. And GAE is a minimally invasive therapy that actually is thought to target directly the synovial inflammation. And the early data for GAE is very promising and supports that hypothesis. But ultimately, we're going to need sham control studies as well as other RCTs to validate. So I'll stop there. Thank you guys for your time.
Thank you for stepping away and speaking with us. I just have 2 quick questions for you, and if you're okay with it, we do have a couple questions in the chat as well. If you don't mind sticking around and asking or answering those.
No, my pleasure.
Our first question is there a role for an algorithm that tries genicular nerve blocks or ablation before GAE?
There's an echo, right?
Oh, sorry, that's my fault.
No worries. So the question is related to nerve ablation. And I think that, if you look at nerve ablation, what is nerve ablation doing? Nerve ablation is burning the nerves that basically surround the knee joint. And it's a very effective treatment in its own right. And it's another tool that we have available to us. But nerve ablation doesn't address the inflammation. What it does is it sort of deals with patients who have probably burned out inflammation, have mainly mechanical disease, and I view it as a very complementary therapy to GAE in that patients have multiple reasons why they'll have pain with OA, whether that's mechanical, like due to their true bone on bone, sort of alignment issues. You're not going to solve that by, embolizing their arteries. But some patients just have true inflammation as the source of their pain. So what you do, so I don't think they compete with each other. Usually I will sort of assess to see what I think the cause of their pain is and sort of go with that first. So, in a lot of ways you can kind of try one, and if that doesn't work, it's like, okay, well then actually maybe your pain was the other thing. But, you can kind of a lot of times deduce that up front.
All right, and my final question before we let you go, is there a role for GAE post total knee replacement? And do you see that it's equally as efficacious?
Yeah, it's a great question. So GAE, just for everybody's education, was a therapy that first evolved. It's been around for actually for decades, but we primarily did it for post TKA patients who had what's known as hemarthrosis. They're basically post surgery. They're basically bleeding into their joint, and we would go in and we'd embolize it for bleeding, right? And now it's evolved for arthritis, and now it's kind of now that we're doing it for native OA. Now it's evolving back to post TKA for something what you asked, which is what's known as post TKA refractory pain. Up to 20% of patients who have a knee replacement will actually develop what we call a failed arthroplasty, meaning, for whatever reason, the arthroplasty actually doesn't sort of cure their arthritis or cure their pain. There's a lot of different reasons, loosening, infection, alignment issues, all that sort of stuff. When that's all been ruled out, you can try to do things like nerve ablation as well as embolization. The literature is on it is pretty limited. There's a pilot study from France on this, as well as a recent study I believe that was just published. So we're starting to get, and that one was from Argentina. So we're starting to get some early data to support doing it for that as well. So I do offer it to patients. It's just not as common, obviously, as knee OA because there's so many patients with that.
All right. Well, thank you so much for your time, and hopefully your case goes well. I don't know if you're going back to the suite
No,
right
my,
now.
my partner came, so I'm good.
All right. Well, thank you so much. And with that, we're going to transfer over to Dr. Dermengian. He is a frequent presenter, and we heard Dr. V talk about him a little bit earlier. So take it away.
Hey guys, I'm Dr. Dermengian. I'm here with my partner. We're doing cases too. Can they hear it? How are you guys doing? So we're doing some legs today, and I'm going to be talking about spinal cord stimulators, which a lot of our patients are also going to be needing. Let me share my screen here. Okay, so spinal cord stimulators. So naturally, I see a lot of PAD patients, do a lot of arterial angiograms, and a lot of these patients are diabetic as well. By the way, the person on the screen is Dr. Consagra. Oh, thank you. My IT guy. So, dealing with a lot of PAD patients, we see a lot of diabetics. And in these patients, they come with foot pain. And a lot of times it's mixed, right? So some of it's ischemic, claudication. Hello? But a good amount also have peripheral diabetic neuropathy. It's a very common problem, kind of pushed aside by a lot of maybe PCPs. They just put everybody on maybe meds and kind of ignore them because there isn't too much to do. There's a huge global burden. 50 million people worldwide have this problem. 1 in 3 diabetics have diabetic neuropathy. And the diabetic neuropathy can also be painless and also painful. So those patients that come in saying they have burning, tingling pain on their bottom of their feet, about 25% of people with diabetic neuropathy have severe pain. And these are the patients that are always complaining. They can't. It hurts for them to walk, hurts for them to sleep. And then incidentally, there's also been a higher amputation risk seen in these patients. And that's from a multifactorial, right? So they also have decreased sensation. So they might have wounds that they don't recognize. They might develop pain from a wound or painful ischemia and kind of ignore it and present later, a little advanced. And then the third is also by the time they get to severe diabetic neuropathy, painful, their disease process is usually much more advanced. So just something to recognize if you're treating this diabetic PAD population is you're going to be seeing this a lot. And it puts a huge economic burden on our healthcare. So all these patients are very, they complain about this problem, but nobody's listening to them. So it's important when you're in clinic to pay attention to everything that they're saying. What type of pain do they have? Where is their pain? What time of day is it affecting them? It's disturbing their sleep, disturbing their activity. And it does also have a mental health burden too. There's a higher depression rate seen in these patients. So again, just something to acknowledge, to talk about in your clinic. Again, this goes back to clinical IR and why it's so important. And then again, 40% report significant work production impacted. And they've all again, like I said, they've been tried on multiple medications. Their PCPs don't really have much to offer them. They're also seeing podiatry who's kind of managing their gabapentin, for example. But let's get to the medical treatment, right? So almost all of my diabetic patients, a lot of them are actually already on gabapentin or some version of that. But unfortunately, only 30 to 40% even respond to that medication. Some are just they're getting used to just dealing with this problem, right? But again, in the elderly patients, it starts to have side effects, dizziness, cognitive impairment. A lot of them can't tolerate it, so they discontinue it. Same thing with tricyclic antidepressants, poor tolerable profile, right? So a lot of anticholinergic effects. Patients don't like it. They self-stop the medication, and that's one of the problems with just medical management of this diabetic peripheral neuropathy. It's really painful. And again, they all try topical agents, creams. They go to the pharmacy. They're trying all sorts of medications to help their neuropathy. So what's the mechanism of action of this type of pain, right? So there's a gate control theory, which came out in 1965, kind of changed the way we look at pain. So essentially, we're looking at two different types of pain fibers, the small diameter C fibers and the large diameter A fibers. The C fibers are the ones that cause the pain, right? Either sharp pain or again, this type of neuropathy, right? The burning pain that our patients complain of. And then you have sensory fibers, the A beta fibers, which I guess the best way to explain it is rubbing, touch, things like that, right? And the theory is that there's some modulation that happens in your dorsal column. And that goes back to why you rub something when you hit it, right? If you bump it or cut your hand, you end up rubbing it, because what happens is the rubbing activates the A beta fibers. They modulate the pain that you're feeling and decrease the pain, right? There's all sorts of other pathways, but this is the main mechanism under how SCS came out, spinal cord stimulation. There's neural symptoms that come as well, but this is the dominant one we're looking at here. Again, kind of explains why you rub your hand or your leg every time you bump it. Okay. And so now there's different types of spinal cord stimulator modulation, right? There's a traditional one, which is this paresthesia based, the original version. So low frequency, 50 to 100 hertz. Again, so this type of spinal cord stimulator creates paresthesia, essentially that rubbing sensation, to essentially mask the pain that they're feeling, the burning pain. And a lot of patients do like that sensation, but it is something that they feel. So they are feeling these paresthesias, and you can use it also to map where their pain is. But there is a certain number of patients that don't like the paresthesias. It kind of bothers them. They're always feeling that, rubbing or type of sensation. But it does help with pain, about a 50 to 70% response. The next step of SCS, and this is what I personally use more for diabetic neuropathy, is this high frequency, 10,000 kilohertz. And this is, we mentioned this as a paresthesia-free type of stimulation. And I can get to the trial that talks about it, but it has a very good response rate, about 85 to 90%. Again, this is paresthesia-free, high frequency. The theory behind this is less well understood compared to the traditional. There might be some depolarization or other stimulation of the nerves in that area. And then there's a third type of burst stimulation. Again, this is subthreshold, so closer to how high frequency works. Again, it's considered paresthesia free. It works well when there's a lot of mental or emotional type of pain happening as well. And again, use a lot for back pain, more chronic back pain patients. So the Senza PDN trial, this is looking at the high frequency SCS. Took 216 patients and split them up into 108 into the treatment group, 108 into the control, and it was a multi-center randomized control trial, so a big level 1 evidence trial. And again, these patients have had chronic foot pain for more than 4 months, have tried at least 2 types of medication, and this can be topical as well, and they all have a VAS scale of greater than 5. And again, it is only for diabetic neuropathy, so some of the exclusion criteria included patients with prior back surgery or spinal stenosis. And it showed an amazing result, right? So 85% in the SCS group responded with greater than 50% reduction. Only 5% reached that greater than 50% pain reduction in the medical management alone, which is kind of what we see in, when I see with my patients. They're all on medication, but they're still having that pain. Maybe it helps a little bit, but not entirely. So again, this trial was amazing. It showed a reduction from a 7.6 VAS to a 2.1 with 71% pain relief. And again, another important thing is that it lasted out, and we'll get to that slide as well. Secondary outcomes really helped quality of life, so it helped them sleep, 72% versus 8%. Physical functionality, quality of life satisfaction. They looked at all of these factors, and it's a huge difference between SES versus medical management. And another outcome that we kind of saw from this is it also helped increase the neuropathy, right? They got more sensation. So I'll get to that on the next slide, actually. So again, this shows the durability of our trials, right? So a lot of, we talked about in the last presenters touched upon this, is that some pain trials can be due to placebo effect, but does it last out to 24 months, right? And this did. So at 6 months, it was 85%. At 24 months, it was still 82% response rate. And go into the neurological improvements again, right? So 65% of these patients actually showed improvement of sensory function, right? So they were starting to get some sensory function back. And about 28% showed this on nerve conduction studies. So this is an area that I think should be explored some more. It could be very important, especially in our PAD population who have numbness as well on top of the burning sensations. Again, this just shows how well it was like a landmark study with a great success over medical management alone. So safety profile, there was a 3.2% infection rate, 2.1% device malfunction, and less than 1% lead migration, which requires you to go in and adjust it. But again, comparing to what medical management does, right? These patients can't even tolerate sometimes being on these gabapentins or antidepressants because it affects, especially our older population. Again, this goes back to patient selection. So how do I select my patients? Again, it has to be diabetic peripheral neuropathy, and that's where I'm focusing on, especially in my PAD population. The pain has to be at least 4 months. But again, this is stuff that these patients have been dealing with for years most of the time. And they almost always come with at least they've even either on gabapentin or have tried gabapentin. If they haven't tried anything, again, I'll initiate that process. Mainly because it's required to show that they've at least tried and failed medical management. But they've all tried topicals at least, and we always try one oral medication as well. And then I kind of reviewed, do they also have back pain? Have they been worked up for spinal stenosis? Have they had prior, spine surgeries, back surgeries? Because that all affects what the approach is. And again, this VIR is specialized in image-guided procedures, so why shouldn't we enter this space? When we started doing this procedure, the reps were like, this goes much faster in your hands compared to others, because there's a lot of specialties entering this space. It's gaining a lot of traction if it already hasn't, but it's something that we all have the expertise for. It may seem a little bit scary at first, but you have, as IRs, we are trained excellent in image-guided procedures. So again, level 1 evidence, superior efficacy compared to medications, potentially regenerates nerve function, which again should be studied some more, durability of the results, and favorable safety profile. And that's it.
All right, thank you. We do have a couple questions in the chat. There's some coming through. We would like to know if you run into challenges or competition with anesthesia when establishing this practice and how you approach that.
There's going to be competition everywhere, but again, the important thing goes back to clinic, right? A lot of these patients are your PAD patients. They're coming to your clinic, so building a relationship with these patients, and then that's one place to start, right? It's an easy, you have your own patient panel, easy place to start building a practice instead of going out and trying to compete with anesthesia. You already have relationships with podiatrists and PCPs, so that's the second spot where you go and you start to talk to them. If you've already done a good job for taking care of their patients' wounds, obviously the next step is, you can start to create relationships and grow from there. So personally, I haven't had much competition when it comes to that, but it's taking care of your patients, building relationships with them, and building relationships with your referring providers.
Okay, and then we have 2 more good questions in the chat. Are there any studies targeting patients with chemotherapy-induced peripheral neuropathy, or most of this just studying diabetic populations?
I've run I run into one or two patients that way. I don't think there's good data on it. I would have to go back and look, but as of right now, we're just focusing on peripheral diabetic neuropathy.
Okay, and then our last question for you, does pain control in PAD patients limit your clinical evaluation of symptoms, like rest pain, etc., to monitor disease progression?
Yeah, a lot of my patients have, mixed pain. They have back pain, they have neuropathy pain, they have ischemic pain. So it does get a little bit tricky too, especially once you throw in venous disease on top of that. So it's just getting experience trying to figure out um, what type of pain they're experiencing, and then kind of also evaluating all the different. So you got to be able to evaluate back pain, you have to evaluate neuropathy, you have to evaluate venous and arterial disease and see, okay, their arterial disease is minimal, right? And most of their pain is burning type pain. This is not a PAD issue, this is a neuropathy issue. Or most of their pain is in their toes at night, and when they're laying flat versus and they have a SFA occlusion. I'm just making it really easy and obvious, but it's working through these algorithms to try to figure out what's causing most of their pain and which you should address first, right? If they have a long segment SFA occlusion, they're having claudication, but also have venous disease. Obviously, you want to treat the SFA occlusion first to help their claudication. It's less likely venous claudication, but that may also mask it. So if they're not fully getting better, then you want to treat their venous disease as well. So there's a combination. You want an algorithm of most critical and most likely causing their pain, and work your way down.
All right, well, thank you. If you don't mind, there's some discussions happening in the chat. If you have time to stick around and answer some of those, but I think we're going to go ahead and hand this off to our next section.